Hi everybody, welcome back to our Fertility Q&A Live. Tonight we're going to be talking to Dr. Kenneth Gelman of IVF MD, and as soon as he joins us, we'll go ahead and bring him in. So we actually have a few questions already submitted, but I'd love to encourage you to submit your questions as well. We're going to focus on ways to actually help improve your fertility, whether it's naturally or, I see Dr. Gelman here, or in preparation for a medicated cycle. And we've been working together for quite some time. Hi, Dr. Gelman, how are you?
How are you?
Good, great. Could you introduce yourself to those who don't know you already?
Yeah, hi, it's good to be back. I'm Kenneth Gelman, one of the doctors at IVF MD. One of the, how many now? We got 13, I guess, 14.
Wow.
We keep adding doctors. Can't keep track. But I'm in the Cooper City office with Dr. Wood and Dr. Gerkowitz. So it's a pleasure to be here. And it's always fun to do this.
Great, yeah, I'm excited because every time I always learn something new, and we're saying we've been working with fertility for over 15 years, 20 years, I don't know, a long time, since
it's
2004.
wild.
So
Yeah.
you always learn more every time. There's always
Yeah.
new stuff coming out. There's a lot of interesting things that came out this week with men. So we could talk a little bit about that as well. I'd like to pick your brain. But first, we have a few questions also that were submitted to us. So for you guys joining us right now, I'm Farah Duro. I'm a reproductive acupuncturist in Hialeah, now our new office in Hialeah Gardens. And we also have a satellite location in Coral Springs. So we've been actually working
You
with
open a satellite? I didn't
Dr.
know that.
Aracena. Dr. Aracena's there. She sees our patients in
Oh,
Coral Springs. So for those of you who've been asking us that are up north, we do have a partner in crime that can also assist with transfers, things like that as well. And I know the holidays are coming up. Everybody's a little stressed, anxious, so we're working a
yeah.
little bit on that with everyone, and also trying to get in cycles and trying to get in transfers. As you know, you guys are really busy next month with lots of transfers for people that are trying to do their IVF cycles before the end of the year.
Yeah.
So we're just trying to work with where everybody is, and some patients are trying naturally. We're helping with them, or they're thinking about, perhaps that's you, like thinking about doing a medicated cycle in January or February of next year. So you have a few months to kind of get everything nice and ready, get your circulation better, improve your mental outlook, help with stress, and hopefully have a great cycle coming up, and help everything work better. So that's what we're here for. And then we also have a wonderful massage therapist who is here as well. We combine our acupuncture treatments with massage sometimes, with abdominal therapy as well, and work with diet, helping with Mediterranean diet and all those things as well. So it all comes together, hopefully, and to a better, healthier cycle and implantation as well. So a healthy pregnancy, it's the ultimate goal.
Great.
So as far as our questions go, I'd love it if you guys would jump in also and ask questions. That's what we're here for tonight. And we have some questions that were already submitted as well. So I just want to say welcome everybody, and we will get to your questions whenever you type them in. And feel free to pick our brains tonight. Now we have our first question. Is IVF recommended for someone who only has PCOS after 3 IUI cycles?
Well, the difficulty with PCO is generally related to ovulation. I mean, there's some PCO patients that, spontaneously ovulate and they get pregnant on their own. We've all seen them. And some have maybe more regular type cycles than others. And then there's the other more difficult case that just doesn't get a period at all, or doesn't ovulate, obviously. And then they fail maybe even to respond to Clomid or Femara, or even combinations of the two, where they just don't ovulate, or they respond so poorly that, they're just not, or they ovulate. Some of them may even respond and they won't get pregnant. I mean, so it's like, and that becomes a situation just like anybody else, who has unexplained infertility, who may not have been getting pregnant on their own, and they ovulate, And sometimes we try these medications, oral medications with those patients, and they don't get pregnant either. So it becomes the same situation as a PCOS patient who responds, ovulates, but isn't getting pregnant. Obviously we have to check their tubes and sperm counts and make sure, we think they have adequate, sperm and adequate sperm that can do the job, and the tubes are clear, et cetera, et cetera. But aside from all that, I mean, it's the same situation as somebody who's just not getting pregnant, period. So that question also is meant for, more generalized population of patients too. But in any event, if you're not getting pregnant after 3 IUIs, I mean, there's always like a rule of 3 that everybody seems to follow. And there's no hard, fast rule and says nothing's set in stone here and says you couldn't do a 4th IUI or even a 5th. I've had patients do 6 and 7, where we really felt that they can get pregnant by doing this. And it's happened, the 6th to 7th time it's happened. And people say, well, why the heck doesn't it happen on the 1st or 2nd or 3rd try? You're not going to have a good answer to that. But maybe there's a little endometriosis that's playing a role there also, because, we know PCOS patients can have endometriosis also. They can coexist.
Yeah, definitely. We see that.
So that may be what's going on in that case. But, it also depends on the age of the patient and how anxious you are. And, so there's a lot of factors here. How good the sperm is. I mean, do you want to pursue this longer? I mean, are you okay with, doing another cycle and having a disappointment, again, and, or is it better for you to move on and take the bull by the horns? Because, the main thing about IVF is, yes, it does help people get pregnant faster and more effectively. It preserves fertility. And nobody really talks about that. And that's one of my key discussions to every patient I talk to. It preserves your fertility. If you're a good candidate for doing this, you're going to have embryos or eggs or whatever you end up doing. I mean, that's a fantastic thing. So it takes a lot of the guesswork out of it, and it also, it allows you to do things that you can't do with anything else.
Yeah, so that's a good point. And then someone just asked, does an endometrial biopsy have any risk to the uterus?
No, I mean, no. I mean, it's done pretty carefully, especially, in our practice, we do so many of them. And, we're so good at it that, nothing happens. I mean, there's some cramping involved, so it's uncomfortable. Some people, can have a little spotting or bleeding afterwards. Occasionally, you can get a low-grade infection called endometritis. And very, very, very rarely can you perforate a uterus or something like that. But it's not something that's very commonly encountered. So it's a very safe procedure.
All right. And I remember you guys used to do endometrial scratching. Is that similar? Or
Very
okay,
similar, very similar. Except we don't send the biopsy specimen to pathology.
Okay.
So it's the same procedure, and it's maybe a little bit more irritation involved, but it's basically the same thing.
So would you do the biopsy also in the place where you're hoping those embryos will implant?
A lot of times we do.
Okay.
There are patients who, for example, where we determine from certain testing they might do that they may require an endometrial scratching in order to help them implant embryos better, because the scratching procedure induces these implantation chemicals, I guess, for, lack of better words, to help the embryo implant, that the irritation in there induces, blood flow and chemicals to be made locally. So it helps the embryo. So sometimes we may plan it so that, particularly before that's why frozen embryo transfers are so good, because you can do a scratching in the month before your actual transfer and essentially combine it with an endometrial biopsy and send a sample to make sure you don't have any inflammation going on in there, abnormal inflammation, like a bacterial type thing where you might need antibiotics, endometritis. So you detect that at the same time, and you're doing the scratching at the same time. So it could be combined.
And how do you guys decide where to implant the embryo? So I get that question too.
Well, I mean, I think, you have to be good at, at seeing where the endometrium is on the ultrasound. You need a good ultrasonographer. There's nothing like a good ultrasonographer on the day that you do your transfer. I mean, that's the biggest thing that I look for and insist on. And obviously if the endometrium is well prepared, it's usually hyperechoic to a certain extent from all the progesterone and things like that. But basically you try to, put it right into the middle of the cavity, right in the middle of the endometrial cavity. And it's very easy to see when you have good visualization. Occasionally visualization is difficult, and or the transfer it's difficult, but for most of the time it's, if the bladder's full and it's an antepartum uterus, you could see pretty well and you know exactly where to place the embryo. And that's usually what we try to do.
All right, great. And I have a question here. Do you recommend tubal surgery for unblocked tubes versus IVF first? Scar tissue blocked both tubes after, this looks like UFE and fibroid myomectomy.
Yeah. Well, again, depending on your situation there, your age, and, do you, like I said before, do you want to preserve fertility at the same time and create embryos and have the ability to get pregnant 5-10 years from now, more? I mean, IVF would be a perfect solution for that situation instead of going in surgically, where the potential is, unless the surgeon's really, really talented, you can create more scar tissue. And what's to say it's going to be successful? It might be successful initially, and 3 months later, there's more scar tissue there. So it's hard to know, how good that surgery is going to be. And, if you're not getting pregnant after 3 months, you're going to have to do another HSG, check those tubes, and God forbid there's a problem there, and you may end up doing IVF anyway.
Is that common to see the tubal blockage after a myomectomy, or?
Well, it depends. I mean, where the fibroid was. I mean, not normally, unless they're doing a laparoscopy. They must have been doing a laparoscopy at the same time. Or the fibroid was so big and probably serosal, or, was obviously on the outside of the uterus, and so that's the only way to access the tubes, unless they block them from the inside.
Okay. So yeah, I mean, the atopic rate might be, I don't know if it's high or not, if you've had blockage before, I'm not sure. But that might, be also a factor, but a lot of patients worry about their tubes affecting the implantation as well, right? If there's hydrosalpinx or some fluid leaking.
Well, I mean, but routinely before any IVF procedure, we always do an HSG. We make sure, the tubes are not in any way going to be participating in any implantation failure here, because, the fluid there is not a good thing for the endometrial cavity. It's not, because the tubes communicate directly. So, we don't want anything that has, any kind of negative aspect on implantation involved. So if the tubes are dilated in any way, or we think the tubes are going to contribute negatively to implantation, we're going to take care of that before any embryos are implanted.
Well, we're getting a few more questions in. Thanks, guys, for asking your questions here. That's great. And she did say she had huge fibroids to answer a question about the surgery. Yeah, so we're sorry to hear of that complication, but we hope that you can get that resolved for sure. And there's a question. I'm 38, have PCOS. This is a guy for PCOS, guys. If you have PCOS, he's been working with PCOS since the beginning. So I've had him on my podcast. He's excellent. So I'm glad we're getting some PCOS questions here too. I have PCOS. I ovulate every month. I've had IUI 4 times, 2 with Clomid, 2 with Femara. Still no pregnancy. Everything good with husband's sperm. Any ideas on what the next step should be?
Yeah, I mean, obviously, you're at the crossroads, and you could decide again what's your age, and how many times do you want to have potential disappointment. Not that if you did another IUI this month, the 5th one, it might work. And as I was saying before, why didn't it work the other time? I mean, one of the options, I mean, many years ago, maybe not so much now, was laparoscopy in that patient to see, for example, from what I talked about before, was endometriosis, because, how else truly would you explain what's going on here? And if this patient's truly ovulating, And I assume you've been being followed by a specialist. Maybe they're monitoring to really see that you are ovulating, or they're doing progesterone levels to see that you did. You know, so assuming that's all the case, I mean, then you would be considered almost unexplained infertility. And usually there's an explanation for unexplained infertility if you look hard enough. So if you really want to look, laparoscopy would be something to think about, but that's surgery. You know, not everybody's a fan of surgery, and, you know, surgery is surgery. It has risks. So, you know, IVF would be a very logical next step, I think, for that patient.
Right. And as far as the saline ultrasounds go, I mean, is that usually done before IUIs as well, or not always?
Saline ultrasounds, we always do also, you know, where we put salt water in the uterine cavity, and with ultrasound, we look at the cavity in 2D and 3D on 3 dimensions, just to make sure there's no polyps hiding in there, or adhesions, scar tissue, blah, blah, blah. Because, you know, again, we're always very concerned about preparing the endometrium properly.
So is that something that might not be done if you're just getting Clomid from your gynecologist, or you're, you know, doing IUI? I've heard of some patients.
They wouldn't, you know, and, you know, that stuff would be found out in retrospect, because that patient, you know, for example, if they did get pregnant with Clomid, you know, they might miscarry if there's something going on in there, and like inflammation or adhesions or polyps or whatever it may be. So after, you know, the miscarriage was, you know, completed, that would be part of the, you know, the assessment, is to look for why that happened. So was there a uterine factor that caused it? So, you know, that would be found on an SIS or sometimes HSGs, etc. But you know, if the patient miscarried, there's obviously other reasons too.
And another question is, does removing retained placenta via hysteroscopy, that 100% cleared scar tissue, have any long-term uterine damage or infection?
Yeah, I mean, and that's a good question. I mean, that's, again, that would be a patient, for example, who might have gotten pregnant again, and or was trying to get pregnant and came in, and we did an SIS and we saw that in there. And the history was, yes, I just had a recent, you know, D&C, or I had a miscarriage, and I had a recent D&C, and we did the SIS and we see retained products. You know, they're fairly characteristic looking on ultrasound, and, you know, that kind of thing has to be removed. Now you need an experienced person to remove that. You know, so when you go in there, they have this new procedure at the MyoSure. They can really shave down the walls very cleanly, and you know, it's usually, my experiences after that procedure, you know, an experienced surgeon, such as we have in our practice, you know, for example, and, you know, there are very experienced gynecologists who would do it. You know, they do a great job, and usually, no, there's no lasting damage. I mean, in the old days, they used to do very rough D&Cs. I mean, that's the old days, and that used to create scar tissue, but not anymore.
Are you guys using anything to prevent sticking of the walls, or, I mean, or you just do a more?
They'll usually put, you know, they'll put the patient on Premarin or estrogens. Sometimes put a balloon in there to keep the walls from, you know, opposing themselves, you know, getting together, right, so the healing can occur. So they'll put them on estrogens usually for a few weeks, and then a couple of weeks, and then put a balloon in there and take the balloon out after about a week.
Yeah, I remember many years ago we used to see Asherman's quite more commonly. Now we don't see as much.
That was from rough D&Cs. I mean,
yes,
the most common cause of that. You know, I mean, you don't see tuberculosis of the uterus anymore. I mean, that was another cause. I mean, that maybe third world cultures you see it, but not here.
Okay, great questions, guys. These are awesome.
Yeah,
okay,
really.
I love them. All right, so what do you recommend to get rid of ovarian cysts that come monthly? Can't imagine this pain while undergoing IVF. I have some thoughts on that too, but I want to hear your thoughts first. Yes.
Oh boy, always. I mean, they're painful. I mean, usually most cysts are not painful. I'm not sure what's causing all your pain.
Well, if they're rupturing, perhaps.
Yeah, well,
that's pretty painful.
I mean, you know, I mean, a ruptured, I mean, how big are these things? I mean, usually you see these cysts that happen just very, very asymptomatically. The person's coming, they're ready to start IVF, and they got a 42 millimeter simple cyst. And, we usually try to get rid of that before we start the stimulation, because, first of all, blocking all the other eggs in the ovaries. And, we want to be able to see what we're doing there. And, typically these things are in the way. So we may try to put them on progestins for 2 weeks or so and see if that'll do it. Sometimes we put them on, and some people get, other cysts persist. Sometimes we want to use something stronger. We'll put them on a progestin OCP and that new oral GnRH agonist, or LISA, and see if that, suppressing all the gonadotropins and, putting them on progestins only might do the trick. And I've had some luck with that in a few patients. Not everybody, but a few patients. And occasionally we've just had if somebody's been waiting and waiting, we'll drain the cyst, but before IVF starts. And then, the problem is they usually come back because we're only taking the fluid out of there. You're not removing the cells that are producing this thing. And, we don't want to send patients to surgery to remove that, but they are a nuisance. There's no question. But usually not painful. Yeah, but when a cyst ruptures, it's painful because it's just like an ovulation. It's like ovulation. When you ovulate, you're rupturing a cyst, but this is just a larger one that happens to be painful. And then, some people, obviously get pain mid-cycle. That's the same process, same thing.
There's been some research on iodine, actually, and cyst production. So we've actually used that for many years in our practice. And sometimes for patients that are prone to cysts, that's been helpful. And also fibrocystic breast. There's even a new, patent out there that it's an iodine, a type of molecular iodine that helps with that. But acupuncture too for pain relief as well, for chronic cysts. Hopefully they're not chronic anymore when we treat them. If we can work with them naturally too, that's always good to do. And sometimes when we do abdominal massage, we find that the uterus is actually tilted or retroverted or something. So it's kind of like congested there. And we're doing work to actually help the blood flow. And that can also help too. And some patients just want to get rid of the cyst so that they can start IVF. Because they're like, I can't start my cycle until this damn cyst goes away. So we work with that.
It really is sometimes very, very exasperating because some of these people you can't get rid of the cysts and we keep delaying them. And, at some point, sometimes we even, depending on how big the cyst is, sometimes we even start them. I'd say if they're, under 20, under 25 millimeters, I probably will start them if they're simple cysts and they're not making any hormones, abnormally. Because some of these cysts, produce hormones, abnormally. And then, you can't start anybody with that.
Yeah, estrogen sky high. And,
the estrogen goes up, or, or it's a persistent corpus luteum cyst. Those things you cannot, start patients.
And sometimes the Clomid can also cause the cyst, right?
Clomid closes a lot of ovarian cysts all the time. I mean, these drugs, they just do that. And, you have to just sometimes wait a cycle or two, and hopefully they just go away on their own. Or again, we try some of those medications I just mentioned.
Yes.
But it's a nuisance, no question.
How long after miscarriage and D&C can I plan for the next FET?
Well,
I'm sorry to hear that, by the way, about the miscarriage.
Yeah, I mean, usually you want to make sure you check with your OB/GYN about that and make sure you get, the appropriate clearance and all that. And obviously, in the next month or two, you don't want to do anything for probably 2 months after a D&C, that kind of thing. And then maybe the third month, you probably need an SIS study to make sure everything's out of there. So certainly under 6 months, you could start again. But I would make sure you clear all that with your OB/GYN.
Very good. Okay, great questions, guys. And I'll go back to a few questions that were submitted earlier today. How much time should I wait to try IUI again after 3 failed cycles? 3 IUI failed cycles, yes.
How much time? What was that?
Should I wait to try IUI again after 3 failed cycles?
Why not go right away? I don't see any reason why you should wait if you're going to keep going on that. I
How many
mean,
IUI cycles generally would be recommended before somebody would, contemplate IVF though at that point? Or
most, as I said before, most do 3,
Mhm.
but some people do less. Some people do 1. Some people,
Yeah.
will want to try it with the idea that, hey, if it works, great. But knowing full well that statistics show that, IUI itself is not very statistically successful
Hmm.
after 1 attempt. I mean, after 3 to 4 attempts, it really starts to get, quote, cost effective. And, it's probably up to 30, 40% after 3 or 4 attempts. But that's 3 or 4 months. And then after 3 or 4 months, if you're not pregnant, well, you got to be okay with that plan.
Hmm.
You got to be okay that you tried it, and then you move on. If that's, so that all has to be discussed with the patient, and then the situation of donor sperm really plays into this because, we got a lot of people coming in that want to use, donor sperm for whatever reason,
Hmm.
same-sex couples, whatever it may be. And that's a big discussion because they all come in, they say, we want to do IUI. Well, sure, that's great. It's cheap for the most part. I mean, the process of IUI is pretty cheap. It's not like IVF, but it's unfortunately not nowhere near as successful.
Hmm.
And the price of donor sperm is very expensive.
Oh.
It's a good, depending where you go. And we only use FDA accredited facilities, and that they run $700-800 a vial for one
Oh.
vial.
For one
So,
cycle, or can you use that for
well,
other?
that's one vial. That's one IUI per
Okay.
month.
Okay.
So if you're going to do, 2 IUIs in one cycle, well, there's $1,600 right there. A lot of money.
Mm. Oh, right. Yes, because you could do back-to-back IUIs. Yeah.
Well, I do back to back a lot.
Okay.
Not always, but I think back to back is preferred if you can do that. So that's $1,600 right there. And then you do it again. Well, here you're getting up there in terms of paying all this cash and stuff like that. And if you think about it, IVF, you need 1 vial of donor sperm, and look what you're accomplishing with that.
Hmm.
You're making all these embryos if you're fertile, obviously, and you're going to have your fertility preserved. It's so much more efficient. So I'm not poo-pooing IUIs, and believe me, we do them. But I just have to set the record straight here and say, is it cost efficient for you? Is this going to be something you're willing to stick in there with, because you may need to do this 3 times.
And the success rates are about a little bit more than like trying on your own as far as with IUIs go, or I mean, what are like your average success rates right now with
Probably
those? Or
I mean, it's like a national average, 11 to 18%.
hmm. And IVF right now is at like, what would you say?
Depends on the age.
Yeah, yeah, like in
Depends
your
on
30s or late
yeah
30s.
yeah. I mean, you're talking 40-50% success.
Hmm.
Probably a little higher in some cases. I mean, if you get a chromosomally normal embryo,
Hmm.
whether you're 30 or 40 or 20, if it's truly chromosomally normal, it's rough. I believe it's a 56, close to 60% implantation rate.
Very
Pretty
good.
good.
And I have some more questions coming in here, I see. My Ari says, I don't have classic PCOS symptoms, but categorized as PCOS since I often have 4-day period cycle day variants, so irregular cycles. Please explain this. Oh, well,
4 days,
PCOS doesn't have to be just cycle irregularity.
right?
There are 3 different characteristics, and you can have 2 out of those 3. So yeah, if you could talk about the difference between, I guess, the classic PCOS presentation and then generally how you can diagnose it.
Well, I just want to clarify something also, because there are some people who, come in, they say, I have PCO. Well, yeah, you may have PCO because you have polycystic appearing ovaries.
Mm-hmm.
Okay. That means when your doctor did an ultrasound, your ovaries have what's called like a necklace sign to them. There's a lot of little cysts or follicles, as we call them cysts, follicles arranged around the periphery of the ovary. So your ovary has a shape, an oblong shape, like kind of like a baked potato. and all the little black circles around the edge constitute all the little follicles that kind of are sitting there doing nothing and not ovulating, and that's a polycystic appearing ovary. Well, that's one facet of the syndrome. So, you can have polycystic appearing ovaries and not have the syndrome and not have anything else. You could be a perfectly regular ovulating person and not have any other stigmata of PCO. So you have polycystic appearing ovaries, not PCO. Mm-hmm. So, and then there's people who have PCO and they can have mild PCO. So they generally have polycystic appearing ovaries, not all. And they usually have an irregular cycle, meaning, 21 to 35 days is normal. So they're falling somewhere out of that realm there. Not necessarily the bleeding phase, but the actual from day one to day one. Mm-hmm. And maybe that's all they have. And then there's the other type of PCO, the more severe kind, generally are weight challenged individuals. They have, cosmetic issues, facial hair acne, acanthosis nigricans, you'll see that fairly frequently, which is a dark skin, velvety looking area, typically around the nape of the neck and
folds in the arms.
Under the arms. And along with skin tags, you see skin tags a lot. Those are signs of severe insulin resistance. So generally those people are severely insulin resistant. Many can be diabetic, not know it. Maybe they do know it. So those individuals generally also have polycystic ovaries on ultrasound, and they have all the other classic stigmata that 99% of doctors learned in medical school what PCO is. Some of them you may confuse with another endocrine syndrome called Cushing's syndrome. Looks the same a lot of times, so that has to be excluded. But so there's different types of, PCO, what people would consider PCO. So I don't know what that patient's really saying there. Her cycles vary from 4 days. That's not really irregular. I mean,
just for 4 days, right? I guess
it doesn't sound right.
It can also, you don't always have to have cystic ovaries to be diagnosed with PCOS either, though, right?
Yeah. Right. So there's other features. Then maybe that patient has a high testosterone, and mm-hmm. They have other chemical evidence of male hormone excess, but maybe your ovaries don't really look that polycystic. It's got to be looked at in terms of a constellation of findings, or mm-hmm. a constellation of clinical symptoms or laboratory abnormalities that have to sort of coexist together. And it's a clinical diagnosis, really, for the most part. A lot of times, not always a lab diagnosis. So the mm-hmm. testosterone level may not be high, the androgens may not necessarily be high, but the patient may have a very irregular cycle, may have clinical evidence of male hormone excess. So there's other things that you can definitely see that don't meet the standard criteria.
Definitely. And then some people just get their glucose checked without insulin. Sometimes insulin is off before the glucose goes up. So we always say just go get like a full workup done, and you guys do an awesome PCOS workup where you can check like for inflammatory markers and all those different things as well.
I think that's really important. That that's part of the PCO panel as we look at the inflammatory markers. Mm-hmm. Just like, and I tell the patients this. If you go to your regular internist, if you have a cardiologist, the good cardiologists are doing this. When you go in there for your cholesterol panel, or if you're really sophisticated these days, like some people are sending these cholesterol panels looking at their large dense LDLs and small dense LDLs and large particle LDLs. Mm-hmm. They're fractionating their LDL particles into the more atherogenic, and along with that whole panel, they're looking at their apoproteins, they're looking mm-hmm. at all these things. But they're also looking at, HSCRP and hemoglobin A1Cs, things like that, to look to see if, those things are elevated as indicative of inflammation that's going on in the blood vessels, which we know happens in PCO due to the insulin mm-hmm. resistance. Yes. Because those are the things that, if you're inflaming your blood vessels, well, that's not good for your heart mm-hmm. and your blood vessels over the long period of time, because that's promoting atherosclerosis. That's promoting deposition of abnormal lipoproteins in your vessels. So, by the age of 40, you could have significantly, clogged arteries potentially, not be symptomatic, but, you wouldn't know necessarily. And, those are the things we're looking for. But, I think not so much in terms of the arteries, we're not cardiologists, but you're inflaming your eggs. You're going to have bad eggs.
The high testosterone and high insulin are not good. Not good combination for egg quality.
Not really. So that's why we send patients to our lifestyles consultants. Put them on metformin or chiron and things like that to try to reduce the insulin resistance factor. Get those insulins down, get them out to exercise, get their muscles moving. Yeah. So all these things we know help.
Intermittent fasting also we've seen work really well. But I mean, I know definitely in PCOS, I would encourage you guys to, if you haven't followed me, I'm at FL Complete Wellness. That's probably because you are on this Instagram. You have.
I haven't heard about it. You've had that great program.
The PCS, we do.
Oh my God. That was an amazing program. That was a very thorough program you have.
Thank you.
That's the most complete thing I've ever seen.
Oh.
And any PCOS patients out there, you ought to love this program. You ought to put that link back up.
I would, yeah. We actually have a link to our podcast on our Instagram bio. You can check those out for those of you who have PCOS, because Dr. Gelman's given really, really thorough interviews, and also we've interviewed many experts from all over the world about PCOS on that podcast. And so we do have things that we help our patients with as far as achieving cycle regularity and helping with insulin balance.
Yeah, that program was phenomenal. You had this, what was that, 13 weeks or something?
It's intense. Yeah, I know. We usually do it once a year around the beginning of the year. So, we're thinking about next year.
Very, very good.
Thank you. And the reason we did that is because we had young teenage girls coming in that were devastated because their self-esteem was just completely, off, and they were getting bullied in school. And yet we would look at their labs and we're like, has anybody talked to you about PCOS? Your testosterone is equal to like an adult male, and that should not be happening at 13 or 14, and so they were just not really being looked at. And we also saw women who were in their 50s with PCOS that had the cardiovascular things you were talking about. Yeah. So it's like, it's, through the full spectrum, not just fertility, but you got to, really address this.
We were talking at one time about really outreaching to pediatricians.
Definitely. It's so
the kids,
important. Yes.
Kids to kind of get them into the corral, so to speak, and, teach them and get them, healthy early on.
Yeah. If you have a diabetic parent, which you're pretty likely to have, or a diabetic family member, if you have PCOS, that's pretty common. You can actually help them, by learning these different lifestyle techniques. So that's what we try to teach our patients and through this program. So we've worked with different people all over the world with it. It's pretty cool. So hopefully we have it again next year, but I'll let you know. But as far as our questions go, we are getting a few more questions in. So does the probability of success for IUI go up significantly if you do go back-to-back IUI in one cycle?
It does. I think it's better to do it that way because, there's something I always observed, and is that your ovaries sort of get on a roll. Even after IVF, it's best to do the next cycle right away if you could, because, the medications seem to just, it's almost like digging for gold. You're starting to dig and dig, and and the ovaries sort of get like rolling downhill, and they achieve a momentum, and the ovulations increase. And you notice that statistically, IUI and IVF get better the second, the third, and the fourth time. So it tells you that the ovaries get more efficient after the second and the third time. So keep going. That would be my advice.
So the back-to-back, I think they're talking about in the same cycle. Like, so you're doing, day 14 and 15. Yeah.
Oh yeah. I would do 2 IUIs in that one cycle, but if it didn't work, I would go right into another cycle. That was my point that I just made.
Okay. Yeah.
Because the success rates get better and better. So it's a definite observation.
So the back-to-back,
I think 2 IUIs are better than one. So make sure your husband abstains for 2 or 3 days before your mid-cycle surge, so he's stored up there no more than 5 days, and go for the 2.
Yeah, and then I would think also with IUI, the timing has to be so crucial, right? Because those little
Well,
sperm don't survive longer than like 24 hours, right?
a
Or
little
is that
longer
true?
sometimes.
Okay.
You know,
All
they
right.
can live longer, but you know that's the thing is you don't know what the sperm survival is of that particular individual. So really healthy males, the sperm can live up to 72 hours. They found it alive sometimes up to a week later.
Hmm.
But you know, I would not count on it. I would probably try to put as much active sperm in there around the time of ovulation. Now, the trick is to make sure the best way to do this is to do monitored IUIs. Is not to just to rely on your LH surge kit, which you know is about 70% accurate, I guess.
Hmm.
But I would document that your surge kit is accurate by doing a mid-cycle ultrasound at your practitioner's office,
Okay.
and make sure that the follicle is there, and you know make sure you know the nurse or the doctor tells you yes you're ovulating, you're about to ovulate. You know, take an HCG shot, get yourself an Ovidrol shot, and take it, and then you know that'll enhance the ovulation process, and then do two IUIs,
Okay.
so that you can you know you'll have a much better idea that hey you know your timing is correct. If you're spending all this money potentially on donor sperm or anything else, make sure you're doing the process right.
Okay. Yeah, that's good advice. And we're getting a lot of IUI questions too, so that's great, because we don't talk as much about IUI sometimes as IVF. But I think that's important, is that's usually the first step sometimes that people will take besides, I guess, being on Clomid or Femara. And as far as, but you don't have to do IUI first, right? You could do IVF also as a first
Of
choice.
course.
Yeah,
You know,
yeah.
we have people walking in, and, you know, and they say, "Listen, I just want to do IVF. I want to get this done." You
Hmm.
know, and you know, it's just again depends on the individual. You know, you have to sense, you know, what the individual really needs. You know, obviously taking a history, but certainly there are people who really want to go straight to IVF, and obviously it's a good decision in most cases. But that's you know, and we've had people do the reverse. We've had people, you know, have done an IVF cycle, maybe, and then they come back a year or so later, young enough, and they do an IUI.
Hmm.
You know, so we have, and you know, people doing that in reverse, so to speak. So there's no magic rule here.
Okay. That's good. And so there's another question. Can high emotional stress actually prevent embryo implantation or a miscarriage, especially in the first trimester?
You know, those are good questions. I mean, nobody knows. I mean, there's been studies done, you know, by psychologists and things like that about potentially implantation failure, possibly related to excess stress. But you know, it's very hard to measure that. I mean, you know, these things are all theories. You know, cortisol, all these you know, these catabolic type hormones that people will make when they're stressed out. Obviously, we know can inhibit ovulation, for example. You know, so I think that you know it probably is playing some kind of role. That's why we insist, you know, on acupuncture. That's why we insist on, you know, meditation, yoga, to change all those hormones to try to help keep you calm, so that you can go through the process a lot smoother, and you know, hopefully not have any of these other extraneous things, you know, participating in something that you know we will at least medically look at for everything and make sure we uncover every stone. But you know, we also want to make sure mentally you're in a good place,
Yeah.
you know, because you know we really can't measure that. It's not like doing an SIS study and seeing a polyp there and say that's got to come out. You know, yes, we know you're stressed, and you know, it's sometimes very hard to tell how stressed somebody really is. But
Hmm.
you know, we know once they start going through this process, it's very stressful. Look, you know, you have to get up early. You have to get to our office early in the morning before your work. There's an extra added stress of driving there, you know, getting to work, getting your phone call in the afternoon, you
Yeah.
know, and the nurse is telling you, listen, you know, your levels are so, let's raise your doses. You're coming back tomorrow, you know,
Yeah.
whatever it may be. And, you know, so there's all those different little stresses that go on there, you know, or you had a
Mm.
previous failure, you know, there's a lot of stuff that goes on in the brain that we just don't understand.
Yeah,
But but
definitely that
but that's
AB.
why these ancillary procedures and things that
Mhm.
you do are so helpful and so useful.
We really encourage meditations as well,
Yeah.
positive visualization during our treatments
Yeah,
too. We do with acupuncture. It has an effect on the
because they
HBO
work.
axis. Yeah.
They,
So
they, they
there's
work. That's why we tell you to do it, because they really work. But you got to
yes.
take it seriously. You got to take the time to do it. People just don't want to take the time.
And yeah, and we know there's a mind-body connection with a
Of
lot of
course.
reproductive issues. So Dr.
Yeah.
Ramasami's on, and I just wanted to
Yeah.
say hi.
My good friend,
I'm glad
Ramjet.
because I've been looking at your research you presented, and I really wanted to ask Dr. Gelman what he thought about this, or you're here, you can chime in also. Has there been any updates as far as male issues with COVID? When I know that we spoke about this, and I asked you this question when I saw Dr. Ramasami's interview, what he did. So anyway, what's your thoughts on any issues that we need to
Well,
talk about with our patients or anything like that? Sperm preservation, freezing, or
yeah. It's probably a good idea for guys, to probably freeze sperm. We don't encourage everybody to do that, but maybe we should. God forbid you get this infection, because
mm-hmm,
there's been some potential thoughts that maybe this virus is hiding out in the testis apparently has a lot of the receptors called angiotensin receptors, apparently, that this virus is thought to bind to, in particular, and they're very highly concentrated in the lung. That's why people are getting this lung disease and, lung problems and things. So there's some thoughts maybe this virus is, maybe laying there dormant or whatever it may be. But, I don't know if it's true in everybody. I think that study didn't show it was occurring in everybody. So whether people want to freeze sperm or not, I don't know if anybody has the answer to that yet,
mm-hmm.
for sure, whether we should do that. But I think those answers are going to be coming soon. And hopefully, obviously, with a vaccine coming up,
Mm-hmm.
which sounds promising,
Mm-hmm.
maybe we won't need to do all that. It's maybe getting through the next 6 months.
Right. Yeah, I think all of us were shocked because we thought, well, fever, we talk about high fever that can affect sperm count or that sort of thing. We
Yeah,
didn't
but I
think
think I think I
asymptomatic
think I
man,
think I
mhm.
think I think the guys. I saw some doctor being interviewed, and he made a good point. He says the numbers, yeah, they're going up all over the place because people aren't doing what they're supposed to be doing.
Mhm.
Period. End. And he's probably right. You know, um, you hear these things. There's not a lot of social distancing certain occasions. With Thanksgiving, I think people should be very careful about that.
Mhm. Yeah.
Um,
There's a lot we don't
Not be
know right now.
complacent.
Yeah, exactly. And
And
I
the
just,
kids and the kids,
mhm.
and things like that, and those things. I still think the kids might be spreading this thing too.
Yeah.
So, people have to do what they are supposed to be doing, and let's get the numbers down. And then we don't have to worry about people getting infected if we get the numbers down. Once we get the vaccine, people get immune, and we get this herd immunity, etc. We don't have to worry about it as much. But for the next 6 months, until we get this vaccine and everybody gets it, well, who's going to get it?
Mm.
Um, then we have to be very careful and do what we're supposed to do.
Yeah, and the ASRM put out guidelines. I think the other day they're not recommending this vaccine during pregnancy yet because they don't know
Right.
enough
No, of
yet.
course not. No,
So
no.
that's it. So okay, we have a few questions to get in
Which is
before
which is an
our.
interesting point,
Mhm.
because if this vaccine is coming out in April, May, whatever it's going to be, what are people going to do who want to get pregnant? Suppose they're already pregnant for 2 months. They're going to have to wait.
Mhm.
Because nobody's going to know what's going to happen in pregnancy. They're not going to do that study.
Right.
That's honestly a big problem
Mhm.
for women. It really is. So, one of the things maybe we should say is, young women, if you're not going to get pregnant right away, and, or maybe you're planning on getting pregnant, maybe freeze your eggs just in case.
Mhm.
Freeze your eggs, or do IVF, put your embryos in the freezer. Get the vaccine and get transferred later.
Mhm. We do have some patients they've received the vaccine already or in the clinical
I haven't.
trials, and yeah, we've actually had we've the partners, the male partners, and they're showing antibodies for the last 5 months, so that's pretty good.
Yeah.
So that's the first round of vaccines, I guess they were tested at but anyway, it's great.
Wow.
But we're progressing. We'll get through this, everybody. Let's take some deep
Yeah.
breaths,
Yeah.
and we'll do it. And in the meantime, keep taking your vitamin C and stay healthy and your antioxidants and eating well and trying to get
Yeah.
your stress under control.
Absolutely.
We do have a few more questions to get in because we're in our last like 10 minutes. So just want to make sure we get these questions in. And make sure I don't miss anything. So confirm, here's another PCOS question. Confirm PCOS with extremely irregular cycles. Oh, wait, did I already? Oh, no, I don't think I've answered this. Okay, have blocked tube and male factor issues. Already recommended IUI, but fear multiple unsuccessful cycles. Are we better off going to IVF?
Oh, for sure. For sure. I mean, if you have a blocked tube, truly blocked, where's that egg going to go? It's not likely going to get to the other side. If you're ovulating, so you may be ovulating on that good side. If you're lucky, 50% of the time a year, So there's already a 50% less chance, particularly, that you're going to get pregnant on that block side. And if there's male factor, I wouldn't get involved with IUIs. I mean, I think they're not worth it. As I said, at best with perfect sperm, perfect tubes, good ovulation, young patient, female patient, 11 to 18%. So you're going to have to persist in there 3 or 4 times. Now you've added an extra layer of difficulty to it. So
the more factors.
You're going to decrease your chances another 50%.
Mm-hmm.
So I would go to IVF.
The more factors involved, the longer it
Correct.
can take sometimes to get pregnant.
Correct.
So
Correct.
it's really important.
And in some sense, you're lucky you've identified a factor.
Mm-hmm.
How many people come to us that don't have anything wrong? And those people say, well, what the heck's the matter with me?
Mm-hmm. Definitely.
Why aren't I getting pregnant? And, in this case, you've identified clearly what factors are contributing. Go to IVF.
I would agree. Yeah. So we have another question. I think I skipped it. Would IUI be recommended for someone with thyroid antibodies over 900? Wow. Yeah,
that's a good question. That's a real good question. There's a question about thyroid autoimmunity. What's the TSH? Because if your TSH is a little high, I'd go on Synthroid for sure. There's some anecdotal reports about taking selenium to help reduce the thyroid antibodies also. The inflammation might help. But that also plays into the immune system about, whether your immune system's revved up in a subclinical way that could be causing, what theories are implantation failure or recurrent pregnancy loss if you've had pregnancies that have been lost, or if you're not been getting pregnant despite, knowing you're ovulating and, documenting that and IUIs, etc. I'd get an immunologic workup too, and maybe you need, some immunologic therapy to help reduce the autoimmunity.
Okay.
But I would probably also think about getting on Synthroid, especially with that high degree of thyroid antibodies.
Right. Why is the thyroid producing antibodies against itself? Like sometimes there's inflammation going on that we need to address as well, right? Because it should be.
No,
so,
it definitely is. That patient's got autoimmunity for sure.
What is the upper age cutoff for own egg IVF, or for using your own eggs with IVF?
Well, no more than 43 with rare circumstance. We stop by that age because the results with, what we call autologous IVF are pretty dismal. There's been a rare case when, somebody is 43 where we might put them through once. We try to check their embryos and make sure they're genetically normal. And then there's some patients who started their IVF at 42 and now turn 43, and they're going through their second cycle and they just turned 43.
Okay.
So there's rare circumstances we put people through.
The next question is, I have hydrosalpinx in left fallopian tube. It's necessary to take off both tubes, even if the right is good. I'll prepare for a FIV. Wait, what's an FIV? FET or FIV? This is FIV.
Frozen egg bank?
FIV? I'm not sure. If you can clarify FIV, I don't think I've seen that before. Um, okay, so is it necessary to take both tubes if there's a hydrosalpinx in the left fallopian, if the right is good?
Well, in surgery, they'll obviously look at the right tube and make sure it really is good. And if they feel that it's completely normal, which is kind of unusual, usually both tubes are affected. But if it's perfectly normal and if it really is, I wouldn't take out.
Okay, very good. And then, yeah, I skipped a few
FIV is
questions.
IVF in Spanish.
Oh, okay, great. Thanks. See, I learned
Okay,
something new today. Thank
there
you.
you go.
Okay. All right, so
FIV is IVF in Spanish. I didn't know that.
I didn't know. Okay, very good. All right, so conflicting info on this. Can I lift my 24-pound toddler pre-post transfer? Will lifting my child cause embryo not to implant or cause me to miscarry?
I wouldn't do that.
Yeah, we don't recommend
I
lifting
would
right
not
away,
do that.
right? Yeah.
I'm very old school in terms of once you have an embryo transfer, I tell people to go to bed rest for 3 days.
Mhm. Yeah.
Minimum of 2 days, but preferably three. And
Yeah,
do nothing. I'm old school on that. A lot of people don't
yeah.
believe that, but I would definitely not do any heavy lifting at all.
It's not gonna hurt to not lift. And I would say, like, if you have a young toddler at home, to just sit on the floor and let them come to you, if that's
Yeah,
possible.
yeah.
I know it's hard,
You're
but
gonna
yeah,
have to
yeah.
adapt to that
Mhm.
situation somehow,
Just for a few days, yeah.
or go to a hotel.
Yeah, I have help, like the stroller
Disappear
and
for a
the,
few days.
yeah,
So
that's a,
that's probably that's what a lot of people do. They just
oh,
go to a
okay.
hotel.
Yeah, maybe a little vacation away from everyone. Okay, so does vitamin D deficiency cause my embryo to not implant or cause miscarriage? How many units of vitamin D do you advise patients to take for FET prep?
Well, the vitamin D, we always look at, the level. We'd like your level certainly over 30, maybe closer to 40 or 50. So it depends on how low your level is in the first place, but we will supplement you. We have a protocol we usually follow, but it can vary between 1,000 to 2,000 a day, 5,000 a day. Some people are taking, 50,000 once a week. Some people take, really high doses in order to get a good level, 10,000 units a day. But your level needs to be monitored. And there's some theories about egg quality of vitamin D.
Mhm.
So I think it's very important to help keep your vitamin D levels intact, not only for this, but I think also for COVID prevention.
And that's, yeah, I mean, definitely, there's like a study that was done many years ago that they were not allowing participants to that pharmacological study for IVF if your vitamin D was below 40, I believe. So it was like, okay, if they don't trust the medications to work, if your D level's low, then maybe, we should look at that too. And so, like, yeah, we talked about vitamin D on other lives. So I think that's important to like look at that research too
No,
about
vitamin
that.
D is
Yeah.
important. I think vitamin D is
Hmm.
more important than you think. It wasn't just your calcium metabolism and all that. It has
Hmm.
a lot of other uses,
Yeah.
particularly in immunity, but also in egg quality. So I think it should be looked at, and we do,
Hmm.
and we make sure your levels at least, in the normal range, but preferably 50 would be perfect.
Yes, definitely. And sometimes it takes a few months to get your levels up to that. So you
It
might want to
does.
try like prepping beforehand,
It does.
before you're thinking of going into an IVF cycle. And we try to emphasize that. And I know you do with your patients, like to try to do like at least 3 months. We treat our patients for 3 months prior to IVF with acupuncture. And sometimes we use different things like Chinese herbs or nutritional strategies with them, massage, relaxation techniques, just to have that chance to do that. And we see time and time again when we don't have enough time, like it's only been a month and they have to go in for a transfer. It's like, we wish we had more time with you because I don't know if that's enough time. And we see
Three
better
months.
results
Three
when we
months
have
is
three
ideal.
months.
I
Yeah,
mean,
yeah.
I saw one study 6 months.
Yeah, I mean, it's like 3 months in the scheme of things. It's not that long. If you've been trying for 10 years, we can do 3 months. And your eggs are not going to age that much in 3 months. We're hoping to de-age them a little bit, help with, improving quality and that sort of thing. But it's really worth it. So I don't know, that's my takeaway. And I know we only have about a minute here. So can you tell us a little bit about how to get in touch with you and if you're still doing virtual visits and
Oh
what
yeah,
you would recommend?
yeah. We do a lot of virtual visits, and actually they're pretty good. I kind of like them. I think it's been great, you know, because we get to all the essential history and we make a, you know, an essential plan, or we just, and then from there we just kind of get people to come in and then we do the testing, and then, you know, we can meet again virtually or, you know, in person, and obviously make the plans for what we need to do. So the virtual visits are great. So if anybody wants to do that, you just call our main number, 954-433-7060 is the main number, and set up a virtual consult, doxy consult, and we can certainly do that. Or obviously in person, we're happy to see you. You know, same number, and yeah, we're happy to you know, help anybody out who needs help, whether it's, you know, anything you want, PCO, IUI, IVF, certainly, obviously. Those are the things that we do.
Cool, very well. Thank you so much
Yeah.
for sharing with us, and thank you guys for your questions. If you want to ask any, or if you didn't get your questions answered, you can definitely DM us, or you can email them, or you can also give us a call. We do virtual consults as well for acupuncture, and we also are here in person. So
Yeah.
Tuesday through Saturday. So thank you guys so much for chiming in. Thank you guys. Thank you, Dr. Gelman. And then we'll see you guys in the new year, since they're coming up on all the holidays. So happy holidays, everyone.
So the next one will be in January, right?
January, yeah. So we'll
Okay.
take December off, and we wish you guys all the best.
Okay.
Bye.
Thanks. Good night,
Okay.
everybody.
Goodbye, everyone.
Bye.
Bye.